Thank you for joining. I believe it's time to get started since it's 11 o'clock. So hello, welcome to the second webinar of a six-part series on opioids in the hospital, addressing inpatient harm. My name is Michelle Bonson, and I serve as a clinical quality consultant on the Compass HIIN team. I am so glad you're here today. The goal of this particular series is to provide participating hospitals with standardized and evidence-based approaches to reduce inpatient adverse events related to opioids. We have a couple brief housekeeping items to cover before we start our session this morning. We ask that you please take a moment and check your phone lines or computer audio and make sure you are muted. We appreciate your attention to this as it does help us avoid background noise during our session. We also ask if you need to step away for the session today, please avoid placing the call on hold so we don't have your call waiting background music playing during our webinar. We also expect that you will have questions and we welcome them as we move throughout the session. Please utilize the chat box to type in questions as they come to mind. Our HIIN team will do their best to answer your questions, but if not able to during the session, questions will be collected and responded to in an FAQ that will be sent out to all attendees. If you would like to speak during our webinar, please utilize the raise hand symbol and we will unmute your line to allow everyone to hear you. Lastly, this session will be recorded and transcribed, so in the event you would like to go back and re-listen to something, or if you had to step out for a moment, that will be possible. Before we dive into the presentation, let's take a few minutes to go over the agenda. After we do a little welcome and introduction, we will briefly recap the first week session, followed by a discussion around the ideal state for this QI activity. From there, we will move into the what and how of a team-based environmental assessment, and then close out with a plan to rally your troops and discuss next steps. So I had the opportunity to introduce myself. Now it's your turn. Please take a few moments to type your name, organization, and role and/or title and your favorite summer food in the chat box. The girls are fired up and the guards are planted. It's really finally summer. At least, hopefully I'm not jinxing us by saying that. Because I'm not able to be here with you live today, I want to thank you for your participation. And by the way, my favorite early summer food is mulberries from a tree in our backyard. I'll give you just a few seconds here to finish up typing up your intro, and then we can move along. I'm sort of sad that I'm not here to see what all your favorites are, but I'll catch up when I get back in the office. Thank you for sharing your information. As previously indicated, this is the second of a six-part webinar series. You will note that the schedule includes a one-week break during the week of July 1st to allow for some time with family and friends over the holiday. Portions of the series may be comprised of a mix of presentation and work time. In other words, the presentation may not run for the entire 60 minutes, so we can allot some time for gathering information around your current practices, finding out where data is housed and how you might get to it, goal setting, and other miscellaneous activities. The goal is to provide you ample time to both absorb and act with minimal time allocated to work on this rapid process improvement outside of our time together. Some of you may have wondered about the commitment of participation, which is on the second page of the flyer. This is an informal agreement that helps keep leadership apprised of your commitment to learning and implementing concepts or interventions within your hospital. It allows for dialogue around what your goals are relative to decreasing opioid-related harm. It ensures engagement and action. We want you to take something away from this series and act on it. We very much look forward to that and hearing about your great successes. And it also involves a willingness and openness to sharing. So kind of know that I might be calling on you. I will always look for volunteers, and it's not my goal to make you feel uncomfortable. I just really want this to be a collaborative environment where people are willing to share and learn with one another. Following each session, registered attendees will receive an email with a link to the recorded version of the webinar. If you have a peer that didn't register but is curious about attending future sessions, please reach out to your clinical quality consultant for guidance. Let's do a little week one webinar recap. During the first session of this series, we spent a brief amount of time discussing the opioid crisis, more time regarding the impact to hospitals and the patients who experience adverse events related to opioids, and wrapped up with an in-depth review of the HIIN inpatient opioid measures. If you were not able to attend the first session, no worries. Each session is placed on our HIIN YouTube channel. I've included a link to that in the bottom of this slide for your reference. Quality improvement in healthcare is a team-based activity. Much like sports, the coach is passionate, able to articulate why it's important to run certain plays, and helps run interference as necessary when obstacles present themselves. In the healthcare setting, the coach may be someone in leadership, possibly a CNO, a medical director, quality director. Each organization will be different. Using the chat box, who in your organization would you envision serving as your coach to address opioid related adverse events? Coach in the sense that this is someone who's really serving in that role and has the traits that we just discussed. If you want to put names, that's fine. If you want to put titles or responsibility, that's fine as well. If you aren't quite sure and need some time to think about it, that's acceptable as well. For those of you that have entered information, thank you for sharing, and feel free to continue to share as we move along here. We're going to talk a little bit about the captain now. Typically, a captain is appointed to their role either because they are respected, diligent, they're probably able to rally the team when they're down and cheer them on when they are excelling. In your hospital, this person may be referred to as a champion. They might be a leader of a particular area or division, or a staff person who has the ability to engage and execute. Again, using the chat box, who in your organization would serve in this role? Ideally, it would be someone different than the coach. However, understanding that resources may be limited, it may be most important to allocate additional time to one person who possesses the traits of the coach and the captain to achieve your goals. Thank you. Thank you for entering your comments. Lastly, I'd like to emphasize that no team equals little to no success. You need to involve the frontline staff at the beginning of the process. Share with them where you are relative to your practices and what your data shows. Engage them in a discussion on what is working well and what isn't. Be careful to not place blame. Make it a safe environment to share and challenge the status quo. Figure out who your starting players are and what motivates the team. Make sure your team is diverse and representative of various perspectives. I would venture to guess that your night staff may have differing views than your day staff, and your pharmacist different from your nursing staff. This is okay. It's really great because the goal is to capitalize on subject matter expertise and create better solutions to address harm. I think it goes without saying that successful implementation of a quality initiative addressing opioid related adverse events will require multidisciplinary coordination. I won't ask you to identify your team at this point. I want to allow the information we've discussed to marinate a bit as we move into the next section of our discussion. We just spent a lot of time going over who should be at the table when you're taking on a QI initiative. As a reminder, the intent of this series is to generate action. Much of the work will involve use of the PDSA cycle. I would venture to guess this is a very familiar process to most of you. This week, we are really in the plan stage, trying to figure out who is doing what and when and why, trying to determine the size of your problem. Remember to use your HIIN data to determine the number of times naloxone is being administered to patients classified as inpatient who are both prescribed and receiving opioids. If you don't have HIIN data or haven't been collecting data, perhaps that is part of your plan. Finding out how to collect, report, and track it with the goal of assuring that opioid-related adverse drug events follow or are incorporated into your organization's overall approach to reducing non-opioid related adverse drug events. I would like to remind you that your clinical quality consultant is available and ready to assist you with collecting and reporting your data to the Compass HIIN data portal. The Joint Commission suggests the following evidence-based actions in core areas to help avoid adverse events associated with opioids. In my opinion, and this sort of tags onto the discussion we had last week, opioid harm is harm, much like other areas of harm in the hospital, where you need to have effective processes, safe and accurate technology, effective and evidence-based tools, and education and training. I would like to just remind you before I proceed here that even though I'm not live, the chat box is open and available for comments and questions. And so the team may pause this recording on occasion to answer those. Feel free to chime in at any point. Now comes the fun part. Are you ready for your assignment this week? Yes, there is homework. I would like you to spend some time conducting a team-based environmental assessment, which some may refer to as an environmental scan when used in conjunction with a formal project. I selected this specific terminology because it is twofold. Number one, I want you to think about your hospital team as a whole, beyond the walls within which you work, to determine who may be able to assist you with your scan or provide you with the information needed to complete your scan. Who is your team? And I want you to complete the actual scan or inventory and document it. So, what does the scan include? Let's talk about the tangibles or things that you might be readily able to get your hands on. Current clinical tools such as order sets, policies and practices related to opioid prescribing through all phases of opioid use. This would include risk screening, ordering, administration, and ongoing monitoring. Any clinical decision support that you have in place or availability of pharmacist or pain management specialist consultation. Do you have computerized orders for opioids, and do they include safety alerts? Staff education on opioids. Who are you providing it to? What does it look like? What is the frequency? And who's providing it? What are the types of risk screening tools that you're using, and when are you using them? This includes respiratory sedation scales, comfort scales, stop bang questionnaire. I'll really be interested to see what types of things that you're able to procure in your environmental scan. There are other important things you should incorporate into your assessment. These may not be as tangible, might take a little bit more work, and you may not have all of the answers right now. But who are the current leading prescribers of opioids in your hospital? What opioids and in what doses are opioids usually prescribed? Do you see variability in different areas or between different prescribers? Is there a particular higher concentration of patients receiving opioids on any particular nursing unit? What are the perceptions of staff relative to problems with the current system, whether it be with prescribing or monitoring? You know, this one might, I encourage you to ask people. They may not be open right away. It may feel a little bit threatening, but I think if you provide the education as to why you're trying to gather this information, it may be more helpful and help them feel more open. And again, if they aren't open to sharing right at that moment in time, maybe they need some time to think about it. Be sure that you let them know that you're ready, able, and willing to take that information when they're willing to provide it. Is there any form of root cause analysis completed when a patient receives naloxone? And if so, who reviews these and what is done in response to the findings? Do you treat these differently than you do other ADEs? That's another thing that I'm very curious about. How mature is your program relative to this? And finally, and lastly, but not least, where, when, and how do you engage your patients and their families when it comes to use of opioids during their inpatient stay? I cannot emphasize enough how important it is to have your patients and their families involved. Having an inventory of these tools will assist you when we discuss best practices during our next webinar. You will be able to do a cross comparison during our time together. An environmental assessment tool has been developed for your use. It covers all the high-level topics discussed in the previous two slides and also has an additional notes section. I know you are high achievers. Please know this is a tool for your use and nothing you will need to turn in or be graded on. I expect you to document to a degree in which you understand your notes, as this tool is for your use both during this jumpstart and possibly after. If you have something else or another format that you prefer to use, please feel free to do so. A sample of the form is included in this slide for your reference. This was also sent out to registered attendees along with the slide deck prior to today's session. If you did not receive one or both of those, please feel free to enter your name and contact information into the chat, or you could reach out to your clinical quality consultant and we will make sure that you receive that information. I love this quote. So here we are. You're going to rally your troops. This quote came from a young man who died in 2004 at the age of 13. Maddie suffered from a rare disorder, dysautonomic mitochondrial myopathy. His three older siblings died from the same condition, and the condition was unknown until his mother was diagnosed with mitochondrial disease in 1992, only after all four of the children had already been born. You might be wondering, what the heck is this all about? Well, it's about you not feeling as though you have to take on the environmental scan alone. It's about sharing your learnings and interest and garnering support from others to achieve your goal. It's about asking for help and establishing relationships within your hospital at the onset of this 6-week endeavor, because as we discussed earlier in this webinar, you have to engage people on the onset so they feel some sense of ownership. So my challenge, not homework, but challenge that goes with the homework, is to see who you might tap into to help you complete your homework more effectively and efficiently, and how you might share why you're doing this homework. Keep track of interesting learning so that you can share with the larger group at our next webinar. I will be very interested to hear what you learn, some of the questions that you receive, some of the challenges you might get, and just your overall maybe awe in what you actually already have in place. Or if you don't have a lot of things in place, just recognizing the plethora of opportunity that you have. We're all in this together. References for today's materials were fairly limited. However, it's important to source materials used, and that's what you see on the slide in front of you. And so here we are. We're already at next steps. I want to thank you for your time today. If you haven't already noticed, this is one of those presentations where it's going to be decreased in time that we're together to allow you for some work time for the rest of the time that we were supposed to be together. I also want to remind you that you will receive an email with links to this presentation. If you have any questions prior to our next webinar on June 19th, please feel free to reach out to me or your assigned clinical quality consultant. The next webinar, if you have not registered, please remember to register. And if you need help doing so, you can reach out to me or your clinical quality consultant. We're always willing to help you. And lastly, I just want to wish you a great week, and I wish you all the best as you work on your environmental scan. Thank you.